Thank you so much, and thanks for the invitation to be here today. So I am an assistant professor in the Department of Health Policy and Biomedical Informatics here. And my talk might be a little bit different than some of what we've heard before, simply because the way the US has approached measuring this health IT adoption and maturity has been at kind of a very high level, nothing with the micro level of detail that we've heard recently. As a quick overview, I plan to cover 3 complementary approaches to measuring the maturity of health information technology in the US, but really this is focused on what has been done to measure electronic health records and their adoption and use, because very little of the effort to date has been focused on kind of the broader health IT landscape, except to include some measures of interoperability. So the 3 topics I'm going to talk about, or the 3 approaches, are measuring implementation of functions to identify EHR adoption, measuring adoption of certified electronic health records, and then measuring meaningful use of those tools. I'll end with a set of lessons learned from our experience in the US, or at least my observation of them. So the first approach to measuring EHR adoption taken in the US was really to define adoption based on a set of functionalities included in the electronic health record. So in 2009, a group of researchers funded by the federal government developed a definition of a basic and comprehensive electronic health record through a Delphi panel process. And I've listed the 10 items required of a hospital basic EHR here on the slide. This effort was really motivated by the sense that until then, there was not a widely shared, agreed upon definition of an electronic health record. And one example of that is in a survey that same year of US hospitals included a single item that said, have you implemented at least partially an electronic health record? And 70% of hospitals said that yes, they had. However, very little information can be gleaned from such a high level statistic. So in order to qualify for a basic electronic health record, hospitals had to state that they had implemented all 10 of the 10 specific functions listed on the prior page. In order to have a comprehensive EHR, they had to have all 24 of the 24 specific functions. And this was measured by surveys of hospitals and physicians, although physicians were only required to have 8 specific functions to have a basic EHR. So in 2008, the statistic that came out was that 9% of hospitals and 17% of physicians had adopted a basic electronic health record. And this basic number has repeatedly been cited and tracked by the Federal Office of the National Coordinator for Health Information Technology, as well as the popular press. The basic number has been kind of the meme on which EHR adoption has been tracked, or at least was tracked for much of the past decade. This use of a binary cut point at this basic EHR, I think is misleading or creates a specific impression in a few ways. One is that despite its name, a basic electronic health record is actually a quite high bar, where in 2008, only 9% of hospitals had adopted a basic EHR, and by 2011, only 28% of hospitals in the United States had done so. And you can compare that to the proportion of hospitals that had adopted a certified electronic health record, that is one that was capable of meeting the meaningful use requirements that were passed in that year. I'll describe this in a little bit more detail later, but the key takeaway here is that far more hospitals had adopted a certified EHR than qualified for this basic categorization. So a rather higher bar than maybe the name would intend. The other key consequence of the way this measure was defined is that it awarded no credit to hospitals that had made substantial progress towards a basic EHR but didn't have a complete one implemented yet. So here I've just plotted a heat map of hospitals and the 10 components of the electronic health record, the basic record that they could have had implemented. And I've outlined in red the 9% of hospitals that qualified as having a basic EHR. I think what is intended to jump from this is that a huge amount of progress towards this basic EHR was not captured by that 9% measure. In fact, if you instead consider this as the proportion of all basic functions that hospitals nationwide had adapted, you come to the estimate that 58% of basic functions had been adopted, as opposed to 9% of hospitals reaching that final goal. Another consequence of this reliance on the basic cut point and the 9% measure is the impression of really dramatic exponential growth in the following years. So from the following decade, going from 9% to 98%. If instead we had taken this progress towards a basic EHR as a basis for tracking progress in the future, we would have seen that really we were at 58%, and then there was substantial but rather gradual growth over the following decade, reaching now almost universal adoption of a basic EHR. So the choice of categorization here was important not only to understand where we were in 2008, but where we went over the following decade. And I think gave an impression of enormous growth when the reality may have been somewhat subtler. So that's one key way in which EHR adoption has been measured in the US and the maturity of that adoption. A second has been through the use of certification. So as part of the HITECH Act passed in 2011, the federal government began certifying electronic health records and vendors' products as being able to support meaningful use. And what that means essentially is saying that they had the ability to complete specific activities towards set standards. Examples of that would be the EHR is capable of e-prescribing according to the National Council for Prescription Drug Program script standard, and was capable of storing diagnoses via ICD-9, CM, or SNOMED CT standards, as opposed to free text or some internal logic. Another key way in which certification was carried out was to ensure that EHR vendors were able to meet specific privacy and security objectives, like detecting the alteration of audit logs. So in this approach, again, going back to this figure, you see that by 2011, 72% of hospitals had adopted a certified EHR. I think a key limitation here is it says very little about what they are doing with that EHR, what functionalities were implemented, let alone the extent to which they were used. However, it at least gives you a sense of what the technologies that were implemented were capable of. So some very basic information, but really useful. The most prominent program related to measuring the maturity of EHRs in the US is the Meaningful Use Program, which provided about $50 billion in incentives to hospitals and physicians to spur adoption of the electronic health record. To attest to meaningful use, providers had to adopt a certified electronic health record, and then they had to attest to using that record in specific domains. And I'll give you a few examples of those in a moment. The difficulty of achieving meaningful use changed over time. So there were 3 stages of meaningful use in 2011, 2015, and 14 for some providers. In 2017, the program was renamed to Promoting Interoperability, reflecting a shift in priorities. Key to the meaningful use is somewhat like the basic EHR label. This was an all or nothing program. In a given year, you either qualified for meaningful use or you did not, and therefore you either received your payment or you did not in that year. So very little incentive for progress towards meaningful use if you weren't there yet, or for progress beyond meaningful use if you had already achieved the criteria in a given year. I think here it's helpful to give some examples of measures. These are, of course, available online, but to give you a sense of what these stages look like, in 2011, stage 1, hospitals were required to attest to 10 core objectives and 5 of 10 menu objectives. An example of a core objective was that more than 30% of patients have at least one medication entered using computerized provider order entry. In stage 2, a few years later, increased the requirements within these categories and also created new requirements. So here the CPOE requirement becomes more than 60% of medications, 30% of laboratory, and 30% of radiology orders are created using CPOE. So a substantial increase in those thresholds. And then there was a new requirement that 10% of patient transitions be accompanied by an electronic summary of care record. So here really about the interoperability and exchange of information. A key consequence of the stages and the increasing difficulty of attesting to meaningful use is that, at least among physicians, there was a notable decrease in how many physicians were meaningful users of electronic health records over time. So taken naively, this would say, there was less use of the electronic health record. In reality, what this reflects is that being a meaningful user, getting that payment was substantially harder. So a key challenge for tracking trends over time is this use of stages. It's also worth noting here, I've plotted physicians leaving or physician participation in the EHR program by their organizational affiliation. And what we see here is that independent physicians were less likely to participate and more likely to leave the program, indicating real inequities in the way meaningful use was measured and impacted physicians that were either in small group practices or were associated with much larger healthcare systems. And that would be reflected also in the patients that they serve. So as part of the meaningful use program, hospitals and physicians were required to submit the extent to which they use the EHR around these specific required domains. And I've plotted two of those here. On the left is the patient-specific education domain, where they state the proportion of patients they provided education to. And the threshold for meaningful use here is 10%. So we don't have any data below 10% because those folks did not participate. And a key takeaway here is, despite this very granular data on the amount of use, the threshold that has been set here is not perhaps particularly meaningful, given that such a vanishingly small proportion of physicians were scored anywhere near that threshold. Instead, vast majority scoring near 30%, near 100% of patients receiving specific education. In contrast, the summary of care records, which I put up earlier, that measure a larger fraction of hospitals were just above the threshold, indicating that perhaps achieving the threshold was reasonably difficult and an indicator of the extent to which the tool was used. But here again, a large proportion of hospitals were able to send a summary of care record for 100% of their patients. In the last year of the meaningful use program, in 2017, it switched from meaningful use to, first it was called advancing care information, now promoting interoperability. And this reflects a reduced role of the government, really, in prescribing meaningful use of the electronic health record. And this, of course, coincides with the shift in the government political party in charge at the time. So in order to achieve the promoting interoperability score, you had to first do the 5 required measures to achieve a score of 50%. And then beyond that, your providers were scored linearly on their ability to perform specific activities. So within these 9 activities, you could achieve up to 10 more points, depending on the fraction of patients that you did this activity for. So here, rather than the all or nothing program under meaningful use, you have the sense that using the electronic health record more could result in a higher score and ultimately a higher incentive payment under this system. In a recent study, we showed that despite this kind of linear ability to achieve a linear score here, the vast majority of providers that participated in this program either scored a 0 because they really weren't able to participate at all, or a 100. So despite the program being designed to measure performance along a continuous scale, the reality is that they have achieved only kind of binary measurement. Either this is too hard or too easy for clinicians. With that overview of the major programs in the US, I'd like to turn quickly to, I think, key lessons learned from our experience. First is the simple limitation of categorical measures. The basic EHR measure provides I think, evocative case of use of a binary cut point, distorting underlying maturity, giving too little credit to progress to that point and too much credit to progress following it. The binary meaningful use design, similarly gave little credit to progress towards meaningful use and little credit to progress beyond it. And I think in anything designed to incentivize further achievement, that can be a real challenge. Moving beyond these kind of binary use cases in the US, any categorical cutoff may penalize nonconformers and distort behavior by saying, these are the things we think are important to achieve the next level or the next stage or the next the next category in maturity. A second important lesson is the sheer difficulty in comparing across provider types. So here we saw with the basic EHR, in the measure that 9% of hospitals and 17% of physicians had adopted it in 2008. This led to important differences in the meaningful use program aimed at these two entities based on perceived progress to that point. And ultimately, the meaningful use program was much more generous to hospitals than physicians. I think this initial basic measure was probably flawed simply because only 8 functions were required for physicians as opposed to 10 for hospitals. So given simple measurement error, of course, physicians were going to look like they were farther ahead. The consequence of this was that hospitals participated in meaningful use nearly universally. Well, only about half of physicians participated because the bar was higher and the payments lower for physicians than hospitals. The challenge of comparing across provider types, I think, is only harder in thinking about other care settings that have really different requirements for what's documented, like nursing facilities and home health. A third lesson from our experience is that use is not linear. Specifying a percent at which something needs to happen in order to achieve a threshold may be arbitrary and may not reflect what's really going on in a organization. We saw high levels of hospitals and providers achieving 100% use, and that indicates that these use measures may really be capturing something very automated and not meaningful use in the sense that we'd like to measure it. And of course, measuring use in this kind of granular detail can be quite burdensome for organizations. So I think to do it needs to be clear that there is value in understanding how often something is used. Something I didn't touch on earlier, but I think is really important, is the simple difficulty in measuring clinical decision support. Most people working in this space, I think, would agree that clinical decision support has enormous potential value to improve the quality of healthcare. However, certainly achieving that promise has been difficult. Under the meaningful use programs and others, there's really been limited attempts to measure how well clinical decision support has been used. In stage 1, simply, do you have one CDS rule implemented? In stage 2, 4 years later, it was, do you have 5 CDS rules implemented? None of this reflects the nuance to CDS, how frequently these things are fired, if they're valued by clinicians or quickly dismissed, and ultimately if they're impactful to patients. So a clear challenge is measuring these well. Another lesson here is the value of targeted use of certification, at least to give you a baseline of who has adopted some level of capabilities. And certification is also very useful when you move into the space of trying to facilitate interoperable data exchange. So more recent certifications have required use of the Fast Healthcare Interoperability Resource, or FHIR, as well as continued use of things like SNOMED or ICD-9 and now 10 to facilitate sharing of information in a structured way. Certification also very valuable as a signal of trust in specific vendors' products and especially around privacy and security. One thing I would highlight from my research in this area and in thinking about measurement approaches moving forward is the value of item response theory to accurately model maturity or adoption of tools here. Item response theory is a measurement framework that differs from classical test theory in that it assumes that items have different levels of difficulty and that not all things are adopted at the same time. So I think fits the context of health information technology far better than measuring means or kind of other psychometric approaches. IRT models take into account heterogeneity in the difficulty and discrimination of items in trying to measure the underlying ability of a provider and hospital, and therefore I think capture the idea of maturity quite well. As an example of this, I've plotted the item characteristic curves for the survey resulting in the basic EHR measurement. And what you see here is varied levels of difficulty in each of these measures, going from items on the left being the easiest to items on the right being the hardest, as well as varied discrimination in how mature or how high the ability of the underlying hospital is based on whether or not you say yes or no to each item. So I think that this measurement framework is uniquely well suited to the idea of measuring progressively harder activities in this area and something to consider around maturity models in general. And the last thing I'll end with is something that has been very limited in the US, which is attempts to measure the really hard stuff. So here we have enormous concerns about provider dissatisfaction with the electronic health record and burnout due to an additional workload created by it. However, we've been really late in developing measures of workload and burnout, as well as even basic measures of satisfaction. And even to date, there's no national effort. These things are hard to measure and hard to measure robustly, hard to understand the root causes of burnout, but I think any push towards measuring maturity would have to measure the impact on clinician satisfaction from electronic health records. We've also seen very limited efforts to measure other hard stuff like culture, readiness, collaboration, climate, communication, and the benefit of the electronic health record. And these are, of course, places where unintended consequences of the EHR seem pretty widespread and something that needs to be better understood. I'll leave you with that. Hopefully this was useful to understand kind of the range of experiences in the US, and happy to help answer any questions.